forefront of mental health care, we gather to celebrate the achievements, acknowledge challenges, and chart a course for continued innovation. Let us embrace the opportunity to honor the past, engage with the present, and envision a brighter future for clinical psychology. Welcome and let the exploration begin.
Absolutely. Today, we kick off the first day of the conference with a fascinating session on rumination as a transdiagnostic process and its management in therapy by our esteemed Dr. Paulami M. Sudhir Ma'am, Professor, Department of Clinical Psychology, Nimhans, Bengaluru. It promises to be an enlightening journey. Ma'am brings a wealth of knowledge, and we encourage everyone to actively participate and make the most of this valuable session. To chair this session, may I humbly invite Dr. Vikas Sharma Sir, General Secretary of the Indian Association of Clinical Psychologists, to come onto the stage.
Yes, ma'am, you can start.
Okay.
Good morning, and at the outset, I'd like to thank the IACP for giving me this opportunity to speak. I am hoping the audience picks up a bit, otherwise I would be talking to the few of you here, and hopefully enough to ruminate over the next 3 days of the conference. This is a topic that I've been working on for a while in different research topics, as well as, of course, in clinical setting, in the clinical work that I do. And I found that it's a very important transdiagnostic factor which sort of contributes to both the onset as well as the maintenance of psychopathology. And I thought bringing this to the discussion would be very important, both in terms of understanding the nuances and how it actually has developed over the years in the context of research and clinical work, but also in terms of how to help clients recognize it, both from a behavioral perspective as well as from a metacognitive perspective, and to look at it as a process that cuts across many clinical conditions which we may not have otherwise recognized to be as being an important factor in those conditions. So I will begin this by talking briefly about why it's important to begin with to have a transdiagnostic approach at all to mental health. So we've been moving from a very categorical perspective to a dimensional perspective to look at clinical conditions, not in compartments, not in separate categories. And often when we have clients before us, we are trying to fit them into which category or which diagnosis. And this is not very helpful when the client is sitting across us and we are planning the psychotherapy formulation or trying to do psychoeducation, and how do we explain all the processes that are actually contributing to their difficulties. So a lot of the biopsychosocial and the psychopathological processes that we know that underlie mental disorders are actually transdiagnostic. Today, I would be speaking about rumination, but we know there are many other transdiagnostic processes, be it perfectionism, intolerance to uncertainty, anxiety sensitivity, and several others which sort of cut across not just common mental health conditions, but even some of the severe mental illnesses. We also know this dimensional phenomena is important because it ranges from normal to pathological, that many of us may also experience intolerance to uncertainty, perfectionism, or have processes of rumination, but it doesn't really amount to a pathological condition. Now, why a transdiagnostic perspective is also important is that many of the symptoms that clients present with are below a certain threshold. They don't fit into any diagnosis at all. And one client may seem to have features of several other clinical conditions, for example, in generalized anxiety or interpersonal sensitivity, which could be part of social anxiety, which could be part of depression, which could even be part of other personality disorders. So we really don't know if it's really one diagnosis that would really describe the client and their problems. The second, increasingly over time, there is a lack of specificity of vulnerability factors, and I think that is something that's not enough to explain individual mental disorders, which I've said about in terms of overlap of these various symptoms across the disorders. Second, the physiological processes also in their etiology. So what are the benefits of a transdiagnostic approach? Why do we need to see these processes across disorders? One, finally, when it comes to management, we are looking at conceptualizing treatment. It's not enough to only give it a name. Of course, a lot of clients come to us asking, what do I have? Is it anxiety? Is it depression? Is it ADHD? So we are having clients, ask those questions, but then having a more parsimonious or a more economical model or way of looking at disorders may actually help us understand the shared vulnerabilities and mechanisms. And I think this is not just important for treatment strategies, but also in terms of conceptualizing and presenting this to the clients to say, okay, this is how all these processes are working, and to actually set treatment targets. So the clinical practice is based more on individual conceptualizations than of the diagnostic specific conceptualizations. And most of us here would remember that when CBT first started in the 90s, there were several disorder specific interventions, and then slowly we moved to metacognitive interventions and formulations. And now we're back with the third wave, which talks about more process-based work, for which again, such an approach would be important. Now, what is a transdiagnostic process? You have transdiagnostic variables and personality predispositions. For example, I've done quite a bit of work on perfectionism also, which again cuts across disorders, and we're looking at it very closely also in personality disorders. But a transdiagnostic process is a mechanism. It's a label given to a mechanism. And as the name suggests, it could be both a risk factor as well as a maintaining factor. So cognitive styles, for example, in mood disorders would be a risk factor, may not be evident, may not be activated unless there is a stressor or there is a precipitant that the individual goes through, may not be a very significant event, but definitely activates this style. And we know that's very relevant in disorders such as recurrent depressive disorders or even bipolar mood disorders, where there could be inter-episode presence of processes such as these, including perfectionism and rumination. And it's not just one. Like I said, this paper by Harvey and subsequently many other papers have discussed it both in terms of very broad and how narrow they could be. Something as narrow as, let's say, thought-action fusion, which could be present, or intolerance to uncertainty, or distress tolerance, versus something that's much broader as well. So these are some examples of what transdiagnostic processes have been there. And while I talk about one today, doesn't mean it exists in isolation. It could coexist with and actually gets compounded or amplified by other processes also. Neuroticism being the most significant one that is overarching. We talk a lot about experiential avoidance, emotion regulation, some of which are skills, broader constructs in terms of the intolerance, as well as the uncontrollability or the need for control that is present. and more specific ones such as attentional biases as well. But why is rumination a significant transdiagnostic process, and why do we need to study it specifically? Because the thing about rumination, and I'll talk about briefly how it has been discussed both as an emotion regulation strategy as well as a risk factor or a cognitive style. And it's one of the earliest processes that has received attention. If you look at very early research, you would find that rumination also has been discussed in predominantly in depression, but subsequently in social anxiety as well. Now, in terms of its correlation with neuroticism, it has stood the test of time, and it's been widely discussed in the response style theory of depression, which talks about how individuals have a specific response style which predisposes them to focus more or amplify more on negative events, and a lot of the other cognitive processes such as personalization, all of that also occur in terms of amplifying the mood and finally leading to an actual episode of depression. It also stems from a lot of work on self-reflection and reflection itself. So the difference between rumination and reflection is something that is often how much of self-reflection turns into rumination and which is helpful and not. And if all of you would probably also be familiar with the fact that work on emotion regulation, and those of you who have used the CERQ know that rumination is one of the maladaptive strategies, which is a vulnerability to depression as well. So defining rumination, in fact, if you say rumination and then you say rumination disorder, you'll get a lot of pictures of cows ruminating over what they've eaten. And so you'll go through a lot of those pictures. And this is precisely what happens to the thought process in a much maybe more unhelpful way. Doesn't help in digestion or doesn't help in any of those processes, but it is repetitive, it is rather passive. And while this definition, which is quite early 90s, says current symptoms, the possible causes and consequences of these symptoms, it could be much wider than just the causes and consequences of symptoms. So the other definition is about thoughts and behaviors that are repetitively, that focus on an individual's content, potential causes and consequences. So both the symptoms here, we mean the affective state, but we know when it actually occurs in a client and the client is reporting rumination, it does not limit itself to the symptoms or their affective states. It could be several other things, including going into great details. It's a very elaborative way of thinking about various events, why it happened, what happened, and goes into a lot of minute aspects of a situation. So it's not just the affect that we're talking about. And therefore, the distinction between what is worry and what is rumination, typically when we say worry, we think about the future, we talk about apprehension, we talk about things that are yet to come, and we know that that's how we understand worry. Sometimes there is an overlap between the two, and worry has been defined as a chain of thoughts and images which are negatively affect laden and they're relatively uncontrollable. So there's a lot of overlap in the definitions, and I think for the purposes of working with the client, it's not very necessary to distinguish between the actual phenomenology of worry and rumination, because the more recent work on the metacognitive aspects of worry and rumination calls it the cognitive attentional syndrome together. So the literature increasingly looks at it as a repetitive negative thinking rather than either rumination or worry. And that's just for us to understand when we are formulating also. So within rumination, I'm just looking at it as the construct itself. Authors have distinguished between what is a brooding rumination, which has been significantly associated with distress, a very self-critical, evaluative point of view. It's also passive, and it's usually associated with underachievement or with a current situation that is not the way it should be or should have been, as against reflective rumination, which is more purposeful, which is more turning inwards, and also has an element of cognitive problem solving without the criticality. So the key thing is the distancing and decentering that we usually hope to achieve in therapy when we're talking about taking a more distant, a neutral perspective and a distance perspective. So there have been several models of rumination, and I won't go into it, just to sort of give you an overview of the different models. I spoke about the response style or the cognitive response style, which has led to several assessments also of rumination as a response style. There is the goals progress theory, when something has actually blocked the progress towards a goal, or there's a failure to make progress towards a goal, which is personally significant and individual rumination to look at how to actually work towards it, and the content is largely focused on that. There are the European models, which a lot of work on cognitive control, and there again there's a lot of overlap between how to actually develop this cognitive control. Cognitive control itself is not limited to depression. We know it's again transdiagnostic and can occur in obsessions, can occur in depression, and several of the anxiety disorders as well. And then the stress reactive model, or the post-event processing model, which is very relevant to disorders like social anxiety, again an overlapping condition where there again you're looking at focusing on events that have taken place but using a self-critical approach. So the stress reactive model and the PEP are both related to events that have taken place. So another construct, and I think those of us who are working with ADHD, we know that mind wandering is something that's constantly reported but not really picked up either by us or by the client. And this is a process of task unrelated thinking, almost without the awareness of the individual. And we know that most of us engage in mind wandering. At least 50% of the waking time is spent in mind wandering specifically, which is the sticky mind wandering and the not sticky mind wandering are distinctions that are made. But what actually happens is that it reduces attention and also hinders performance. That's when it becomes a problem. But at the same time, like everything else, the usefulness of mind wandering has been associated, talked about quite a bit in terms of creativity, ideas that come in at this point of mind wandering, because everything else is at rest. And there is, at that point, although a narrow focused attention, it's possible that when we are in an autopilot mode, we're able to function on other creative aspects of thinking that don't need our attention otherwise. So it does play a critical role in rumination only when the reduced capacity and inflexibility are in combination as well. So many of the interventions on rumination have seen rumination as a habit that has been an overlearned habit, which whenever there is a trigger or situation, it can trigger off the style of rumination. And so it's seen as a very constrained form of mind wandering, which is also referred to as sticky mind wandering sometimes. And when there is less demand on us, immediately one could switch to this mode of thinking. Because it takes up a lot of cognitive resources, individuals may find that they're forgetful, they're not able to concentrate, and that's a symptom they would come with, and that's when you ask about rumination as well in your clinical setting as well. And it's been identified in ADHD, particularly adults with ADHD often report making mistakes or going off, not able to remember, and anxiety disorders, severe mental illnesses, particularly in bipolar disorders, where again there are a lot of co-occurring conditions and mood. Now, this is the self-regulatory executive function model, and I think most of you would be familiar, again, closely linked to the cognitive attentional syndrome, and I'll come back to it when I talk about interventions. A bit about reflection and rumination. The differential relationship has been discussed in the context of negative affect and the correlations with neuroticism largely, and how reflection is more associated with openness to experience. Again, a lot of interventions hope to cultivate this openness to experience in the course of therapy. So the emerging evidence for a long time has been that the need to focus on mental health functioning and how rumination plays a role, and the fact that it's been quite established as a transdiagnostic factor in dysregulation as well. Just these two slides which talk about, one, the consequences of rumination. So when you get a client, a lot of them may not report rumination. They won't say I'm ruminating or I'm having, they might say excessive thoughts, but what they're also going to say is that their behaviors are quite rigid, they're doing the same things, their instrumental behavior in terms of actual problem solving is reduced, they don't seek help, so social support, it intensifies psychopathology and mood, concentration. In fact, a lot of individuals that we've seen have reported sleep and health impairment, and so whenever you get a client with poor sleep or ruminations, it's important to ask for both. And of course, actual problem solving is affected. But in terms of correlates of rumination, like I said in the beginning, it's not something that stands alone. We do need to ask for perfectionism, reduced self-compassion because the content is critical, decision-making difficulties may be present even prior to noticing the mood changes, intolerance to uncertainty because the rumination is actually going on to find the right answer or like a misdirected problem solving, and mood definitely accentuates the process of rumination. So beyond depression, we know that it intensifies rumination and then worsens the dysregulation and then the NSSI and all that, both in personality disorders and in post-traumatic stress disorder. So there's an amplification, and the intrusive symptoms can act as a catalyst for rumination in PTSD. So I'm sure there are other conditions also where it might be relevant, but I thought these have the maximum research as far as the occurrence of rumination as a significant maintaining factor. So there are many challenges to the assessment of rumination, one of which is how to capture it because it's an ongoing process, how it occurs because it's fairly without the awareness of the person, and the person has to be asked to focus on it, and the minute that happens we know that there is a difficulty in capturing it as it occurs. Typically most of the reports have been self-report of cognitive styles rather than actual occurrence rumination. Rumination focused CBT does have a tracking of rumination and avoidance form sheet which has the person recorded real time. And of course, the metacognitive aspects of rumination need to be addressed in terms of what are the beliefs about rumination. There are many positive beliefs about rumination, that it is helpful in problem solving, it gives me solutions. People I know actually lay down and engage in active thinking and then they don't know when it becomes uncontrollable and problematic when they're not able to sleep. So beliefs about rumination and of course the different types of rumination. I just put up this to look at what have been the various widely used measures, and a lot of these, most studies use the RSQ most often because of the subscales of brooding and reflection which become very important in dealing with them. And Franklin's work also has been quite significant. I've already mentioned that rumination could be an emotion regulation strategy, and so if you use the CERT or measures of emotion regulation, you will also get a measure of rumination to see whether that is what is actually happening. I have talked about cognitive control and rumination, but I thought from a neuropsychological perspective, many interventions now designed to look at whether it's important to work on cognitive control deficits and difficulties and then target a lot of other conditions including mood. We had a PhD working on cognitive control where I was a co-guide, and which looked at ruminations and depression using a neuropsychological intervention. So that's another way, another route to identifying and managing rumination as well. But we know set shifting is a difficulty. Again, it's co-occurring with perfectionism, but that stress and stress appraisal is not just the cognitive control deficits, but how one appraises stress that also becomes relevant when you're looking at when rumination gets triggered and maintains as well. So with this background of rumination as a transdiagnostic factor, it would be important then to look at how to address it in therapy, and my next part of the talk would also focus on which route to take, whether to take the route of directly talking about rumination or do your traditional CBT address rumination. And almost all of us have used CBT in some form or the other, but when you're working with depression, we don't directly talk about rumination. In fact, we don't discuss it except in terms of discussing negative automatic thoughts and so on. Traditionally, that's how we've worked on it. But we do know that the initial attempts to target rumination as a symptom was there, but over time, many of the transdiagnostic approaches have used this rather global term of RNT or repetitive negative thought. We recently had a PhD on RFCBT itself. And then of course the mindfulness-based interventions, which again don't talk about rumination, but talk about increasing cognitive control using the mindfulness-based strategy. So I'll run through each of them very briefly. But I think the first important thing is to do a functional analysis, and this is one of my favorites, that you do a behavioral analysis, you get a lot of answers to looking at things beyond a medical diagnosis, because your contextual approach is much more helpful in psychoeducation also. So establishing patterns, looking at onset, incompatible activities, what is associated, when does it occur most of the time, is someone actually having positive beliefs and looking forward to it, all of this is to be assessed, including the beliefs. Skill deficits might set a person off into rumination. I've mentioned perfectionism, and the more you increase the awareness about what function it performs, what is the context and the role, the easier it is to work with an individual later on, because the awareness becomes the key here. So changes in rumination in CBT have been documented. Like I said, it's not often the only goal, but much of the meta-analytical studies on CBT indicates that those that have targeted RNT have larger effect sizes than alternative treatments that don't target it, and therefore it's important to identify it. And this came up much later in the post-2000s with McEnroy and others who worked on post-event processing as well, particularly in social phobia. And there's a recent review, a meta-analytical review of post-event processing across cognitive behavioral interventions in behavior therapy, and that should be accessible. If you look up, you have a lot of studies that have documented improvements in symptoms when you focus on this. And this is just the CBT as well as the metacognitive therapies. Behavioral activation is perhaps now a third wave therapy, but originally seen as part of Beckian work in terms of graded task assignment, increasing activities, and so on. But the assumption here is that it breaks the cycle of rumination by attempting to break the cycle of depression and vice versa. So the focus is on processes that inhibit activation, and we saw how rumination can actually inhibit instrumental behavior. And so by doing that, you reduce escape and avoidance into this thing of rumination. Usually rumination serves as an escape and avoidance to actual problem solving, and that's the function of rumination essentially that we communicate to the client. So the collaborative planning of activities also ensures that there is a sense of agency, purpose, value, and committed action towards goals, and that's where the third wave component of behavioral activation also comes. And we know the mastery and self-efficacy becomes very important in maintaining not just the instrumental behavior, but also in continued engagement of behavioral change. So this is just a cycle which you would get if you just say behavioral activation. But in the third wave context, the rewarding life goals are very important to identify with the individual so that there is no relapse as well. Coming to interventions that actually target rumination, there are several that I will just give you an overview of some of these, and if there are questions, we can take it. Again, a lot of us are using mindfulness in many different ways, but then if we tweak it and focus it more on capturing thoughts, finally it's the client who has to be able to capture these thoughts. It's like breath. It's not something that you can capture for your client and show them how they're breathing, but it's something they have to capture and recognize when it's helpful or not helpful, and that is a continued change. So we know mindfulness increases flexibility, and lack of flexibility is again something that is closely associated with rumination, and therefore the fact that mindfulness enhances non-elaborative, non-judgmental process which is self-aware is probably antithetical or opposite of rumination, and that's where the mechanisms actually may be helpful. It also enhances regulation of attentional control, which again is implied here, and provides more space because we go into a being mode rather than always being in a doing mode, and therefore there is greater flexibility and problem solving, focusing on the real issues as well. And this can be done through combining it with everyday mindfulness practices. We often talk about sitting meditation, but I think it's even more important to show clients how they can do it on an everyday basis and use it more practically rather than just keep it as a sitting meditation alone. So the particular use of this has been in MBCT, again something that we're all familiar with, is primarily focused on preventing relapses in depression. So that's where the core of MBCT actually focused on. It is an 8-week program, but the fact is that the shift to more reflective modes of thinking is what the whole program focuses on, and a very early recognition that these are risk factors for another episode. And that's why we know that in people with more than 3 episodes, MBCT works better than if you work with a person who's just had a 1 episode or just a 2nd episode, because the patterns haven't got established. So the interactive cognitive subsystems that we know are very relevant here in MBCT as well. So the 3 modes, and increasingly we talk about decentering. So the implications of, or the semantics of thoughts are rather looked at, and then the habitual ways of thinking are also targeted very early. Another one on the same line is metacognitive therapy, and Wells is not calling it a 3rd wave therapy, but something that I spoke about in the SREF model. In that, the cognitive attentional syndrome is more transdiagnostic. It helps focus on metacognitive beliefs. But then a lot of the other strategies are very similar to cognitive behavior therapy. And the thing that stands out perhaps in MCT is the focus on the detached mindfulness. And this is a slight shift that Wells does not use meditation, but rather uses a way of detached awareness about thought processes, a lot of metaphors that are similar to what we use in mindfulness, but essentially enhancing distancing and decentering, something that Beck spoke about very early. We use it in thought diary, we use it in a lot of other ways, but that's how the training actually helps them to reduce worrying or ruminating, specifically in the presence of triggers. So these are some of the approaches that have used the mindfulness route and focused on it. A lot of the skills regulation indirectly also focus on reducing rumination as a perseverative thinking process. Now, a more recent approach is again under the family of 3rd wave therapies is RFCBT. And Watkins talks about a model which talks about rumination as a habit, and that people get into unconstructive modes of thinking. And he uses a functional analysis, which again we are all familiar with in our clinical practice, but uses it to identify this acronym of KUDOS, which is context, usefulness of the ruminative thinking, how it develops, and what are the other options you have. So the whole functional analysis is communicated to the client, and they're trained to track and both rumination and avoidance. We tested this in a recent doctoral thesis, and it also uses a lot of behavioral interventions, which is quite simple to practice and for the client to understand also. In a short term, not very severely ill client, for example, moving to more constructive ways of thinking, identifying when they go into abstract thinking modes, using whatever it takes to help them, for example, problem solving, relaxation, self-compassion training is another component, and focusing on values, eventually leading to prevention of relapses. So the hexagon model, as he calls it, looks at goal discrepancies also, and also looking at negative biases towards using ruminative thinking. Now, a few other interventions, perhaps, which are becoming increasingly popular. I was reading on schema therapy, which has another coping mode now, which talks about the repetitive coping mode or repetitive thinking mode, which means that there again, the recognition is that rumination could be some way of regulating emotions. And I think if you're familiar with regulating emotions, we're familiar with looking at being more aware of self and reflection, a lot of interventions actually have overlaps in that sense. The overanalyzing mode is what it's called, and of course we know unrelenting standards are something that is addressed in schema therapy. Process-based CBT, like ACT, talks about it as an inflexibility process, doing more of something that's unhelpful, and if you actually define it, one of them would be rumination along with high standards for self. So with regard to evidence, some of the interventions that I spoke about, for example, metacognitive therapy, actually does not have a lot of empirical evidence. It has a lot of case approaches. It has a lot of waitlist controls, but large trials don't distinguish it very much from the trials that have compared it with CBT. Actually found that there's not much of a difference at the follow-up periods. Again, evidence for RFCBT, there are very few RCTs or other trials, and therefore there's sort of upcoming evidence. Clinically, we know it works, but a lot of support for MBCT for relapse prevention compared to usual care, and significant to moderate reduction in rumination as a way of change. And this is something that's independent of treatment phase, whether it's acute or maintenance. And for MBCT, the number of past episodes really don't make a difference, but the more number of episodes we know is actually important here. Some of the work we've done at NIMHANS is both in terms of the psychopathology understanding of it, as well as the intervention, and we found that in anxiety disorders, it plays an equally important role, along with increased self-criticality also. I will conclude my talk with a few thoughts for us. I know rumination is not a new topic, but one I think that I see a lot of people in the audience who are either working on it. I'm sure Swarna's here with NSSI. There are a lot of people, I'm sure, who worked on it with your clients who've actually helped them, whatever name you call it, but the process is something that you've recognized. And I think if it offers an opportunity to sort of identify risk factors and maintaining factors along with your client if you can develop it. But in general, transdiagnostic approaches are sort of popular now because they're more parsimonious and they're probably more easy to help clients understand what is happening with them. But there's a need to look at it beyond depression and to see how it impacts individuals, their symptoms and their maintaining factors. The exciting thing is also about cognitive control, how one could develop it through mindfulness-based interventions as well as through other neuropsychological interventions and skills training. I mentioned its association with other processes. Very many interventions talk about it in their model, but few identify it in their actual interventions. While they acknowledge its importance, they're not actually having specific strategies. And so there's a need to build empirical evidence for these interventions. The disadvantages, there are very few head-to-head comparisons between psychological intervention, and this we know is because it's hard to have a control group. You need large samples, you need proper designs to actually bring about good effect sizes. And the dismantling of components is always a challenge when you have very similar sounding or similar approaches in therapy. Also, what works for whom is to be established in terms of whether I use RFCBT for a client, do I use schema therapy, do I do what I'm good at and anyway the client will improve because all of them work. So these are questions that sort of come to us when we have a client sitting in front of us. So with these, I end my talk, and these are some of the references. I'd be happy to share it with you if anybody wants it. Thank you.
Thank you, Paulumi ma'am, for an excellent session. And, I think session was very insightful. And in our dealing with the patients, we see patients ruminating, but most of the time it does not become our primary target of interventions. But your presentation has highlighted that rumination is a transdiagnostic process, and if we manage ruminations, then there may be many associated symptoms which might also improve. So it will be interesting to do research specifically targeting on ruminations and then see how it is helping manage other symptoms which may be linked to rumination. So now I request anybody from the audience if they have any questions for ma'am. We welcome Professor Jadid sir. Morning. Any questions? Yes, I think, yeah. She needs a mic.
Good morning, ma'am. My name is Mudita Chaturvedi. I am a clinical psychologist working at AIIMS Bhopal. Thank you so much for the presentation, ma'am. My doubt was that I had, my MPhil thesis was based on pain catastrophization, where rumination was one of the components. And so I was trying to assess the pain catastrophization in cancer patients. So I just wanted to know whether it is a little bit different, like whether the presentation when it comes to physical or chronic illnesses, where rumination forms a part of their thinking process. In terms of interventions, whether there is a difference where, like in how can we work, because they're actually experiencing physical pain. So then the rumination becomes a part of something which they have experienced. So in such a scenario, is there any difference in terms of the interventions, or can we add something, or in terms of assessment, can something be focused on that? That's my question.
So in pain conditions also it's relevant. If you look at many of the chronic medical conditions associated with pain as well as sleep difficulties, there has been quite a bit of work in the recent years using mindfulness-based approaches. In my understanding, it should not differ, but you would bring the client's attention to the fact that this is worsening the emotion and therefore impacting the experience of pain also. So the functions of rumination would be important. The content obviously would be about improvement, treatment, long-term, how it impacts their functioning and so on. So I think adaptation to illness, whether that has been a concern, but there are other factors contributing to using rumination to solve those issues. Lack of social support, could be treatment related, or even debilitation as a result of pain. So some of those could be addressed, thereby that they don't use rumination as a way of directing their attention and problem solving.
Any more questions? Yes.
Good morning, ma'am. It's always a pleasure to hear from you, such a calm and composed delivery in a crisp manner. My question is, I'm Dr. Vasudha Singh. My question is that day in and day out in our own clinical practice, we come across positive and negative belief system. One, what is your own experience? What is more easy to handle first? And what are the research evidences for the same?
First is positive is not really positive, because I think when a person has a positive belief, it's more difficult to engage them because they keep wanting to use that to solve problems. And we've seen clients who look forward to actually engaging in this because there is a understanding that it's also rewarding in that sense. That's why it said it's habit, it's addictive, you go into it, and that's a different element of rumination. So both are equally challenging. The negative ones are trying to control it. So you focus on what they do when they have these biases. When they have a positive bias, how much of a challenge is it to adhere to what interventions you have? And clients who say, I don't want to and I'm having excessive thoughts are the ones who probably are trying to reduce its occurrence by using what we may call a metacognitive strategy or suppress it. And so you have to address what happens as a result of these beliefs.
Very good morning, ma'am, and thank you for the wonderful talk. Ma'am, my question is, as you also mentioned and we all know, that rumination and mind wandering, these are few of the concepts which are prevalent even very commonly among all of us. How do we decide that this is the high time that we need to work upon the rumination or the mind wandering related phenomena, and this is something pathological? Here is the boundary and we need to work upon and focus in the intervention session. So that is what my question is.
I don't know if I'll be able to answer it very completely because I think that's still a question related to, one, I think how distressing it is to the individual, one. Two, how much it impairs functioning. Finally, we come down to what amount of time, and if I say 50% and then what happens to the other 50%. How is it impacting other cognitive functions, the executive functions in terms of my attention concentration on tasks that require it, and how that set shifting is also important. A lot of times that sticky part of it is where the problem comes. So having that discussion in your assessment would become very important. That's why I said a function analysis about actually looking at where all it occurs and how interfering it is would be helpful.
Ma'am, one question to you from my side. Like, how can we, so you mentioned about reflective rumination also, which is positive in many sense. So, do you think that the content of rumination will change with the interventions?
So in the whole approach to transdiagnostic and even in the third wave, we are not looking so much at content as much as the process. Self-reflection, from what I understand, has been distinguished from rumination because of the nature of self-reflection itself and the fact that It is not associated with criticality. The content is also different. But in therapy, generally, when we go into content, it's not as helpful because that shifts depending on the trigger and the event and so on. And of course, there are debates about how much of self-reflection is important and when it becomes rumination. That's a boundary that's hard to sort of draw very clearly.
Okay, ma'am. Thank you. On my personal behalf and behalf of everyone here, sitting here, thank you for your interesting and insightful talk. And I'm sure that we all will now be careful about the ruminative process, which is there across various clinical conditions. Thank you. Thanks a lot, ma'am.
Thank you for the opportunity. And thank you.
Thank you, ma'am, for the wonderful session. Thank you, sir, for your valuable words. And thank you to our audience for making this session so engaging. And now, may I request Dr. Vikas Sharma, sir, our esteemed General Secretary of IACP, to please present Dr. Polami, ma'am, with the certificate and the memento. And now, may I invite Dr. Anvesha Mandal, ma'am, Assistant Professor, Department of Clinical Psychology, IOP Calcutta, to present our chairperson, Vikas Sharma, sir, with the certificate and the memento. Thank you, ma'am. Thank you, sir.
There's a small announcement. There's a slight change in the schedule. The symposium that was coming right next up, which was on psychological interventions for suicidality, work from a tertiary center, with speakers Dr. M. Manjula, Professor of Clinical Psychology, Dr. Meena K.S., Professor and Head, Department of Mental Health and Education, and Ms. Swarna Lakshmi, PhD Scholar, NIMHANS, Bangalore. This particular symposium has been scheduled to be post the inaugural session, which will start at around 12:30.